Mm-hmm.
And so that's one measure. I like physiological measures. The Achilles reflex is slow in about 80% of hypothyroid patients. You probably know that the thyroid hormone regulates the gene transcription for the enzyme that removes calcium ions out of a contracted muscle, enabling it to relax. And if the person doesn't have enough thyroid hormone and doesn't have enough of that enzyme, then when you hit the Achilles tendon, the foot goes down at a normal speed, but it relaxes visibly slowly. And it's another physiological measure of the effects of thyroid hormone on the body, and can give us an idea of whether the patient has enough thyroid hormone regulation or not. Something I use very often is I just ask patients to get a resting EKG, and if the voltage is low, which is very easy to determine quickly looking at it, unless the person has a very severe disease that would be obvious if the person has one of those severe infiltrated diseases. Short of those, it's too little thyroid hormone regulation that causes the voltage EKG to be too low. So that too is a useful physiological measure. And of course, the patient may have many classic clinical symptoms of hypothyroidism, and some of those symptoms could be explained by a low level of physical fitness, and especially a pro-inflammatory diet, deficiencies, for example, of B-complex vitamins that cause neuromuscular hyperexcitability. But as any good clinician does, and I know naturopathic physicians trained in this country spend a good hour and a half to 2 hours with the patient initially, sorting out those sorts of things, considering symptoms in relation to lifestyle and the physical exam, and of course over here they do order lab work, but even short of the lab work. Well, of course, if the patient has classic signs and symptoms, a slow Achilles reflex, a low voltage EKG, a low basal temperature, low pulse rate, and has elevated cholesterol, and maybe is borderline anemic, which can be due to the reduced oxygen demand from too little thyroid hormone regulation, then you can get a very firm feeling about whether or not the patient's likely to benefit from treatment for hypothyroidism. And I think in those cases a trial of thyroid hormone therapy is appropriate because it's innocuous to most people. Even if the patient need it.
Yes, and that's we find here that there's a great resistance to trialling something like thyroid hormone. Like I said, even if it does turn out to not be needed, it's not going to cause harm, whereas some of the other medications that they may be putting people on, like antidepressant medication or high-dose anti-inflammatories, can cause harm.
This is so true. So true. And that's so well illustrated by a colleague of mine in Australia. Because he was suppressing patient TSH levels with T3, the medical board took away his privilege of prescribing thyroid hormone for a year, for 2 years, I think. And interestingly, he told me when he was over here and we were speaking at a conference together, he said, I can't prescribe thyroid hormone. On the other hand, I can prescribe, and he named a series of drugs, and he said, some patients will drop dead on the spot when they first swallow this medication.
Oh my goodness.
But I can't treat them with thyroid hormone, which wouldn't hurt anybody, even maybe a 98-year-old person who's been lying up in a nursing home for a year with no cardiovascular conditioning whatsoever.
Yeah, it just seems insane, doesn't it? Yeah, absolutely. We can't understand it. It seems like common sense, but often there's a lot in the medical profession, as you said, it's not common sense, it's money flow. So, yeah, we have a hard time with that. So, tell me, do you test at all with the blood test, the TSH and the T3 and T4? Are they all useless, or do they give you any indication?
Well, if they are in the extreme, I think they are useful. The range over here now for the TSH is somewhere between 2.5, the upper limit, 2.5 and 3. And if a patient comes in and has a TSH level of, say, 35, well, obviously something's not right there, and we need to check that out. But on the other hand, Robert Volpe, a good endocrinologist in Canada who died a few years ago, unfortunately, pointed out in many publications for his own colleagues, the general medical profession, a patient can have autoimmune thyroiditis with antibodies destroying the thyroid gland for several years before the TSH will ever rise to out of the reference range or before the thyroid hormone levels will decrease. So, and then we have the work of Dr. Bo Wickland in Stockholm, Sweden, a colleague of mine, doing fine needle aspirations and finding that many patients have very active autoimmune thyroiditis with lymphocytes and antibodies destroying the thyroid gland, and those people don't even have elevated antibodies in the blood, and their TSH and thyroid hormone levels may be perfectly normal. And that's in a fairly high percentage of patients. So it makes the diagnosis very difficult. If we use lab work, I always order anti-thyroid antibodies with a new patient who comes in as a primary patient of mine, as well as a TSH and a T3 and T4. I never order them again, which probably frustrates Abbott Laboratories who makes the most money off them over here. But I just want to know initially, are these way out of range? If they're in range, as it's said, that does not mean that that patient does not have hypothyroidism and doesn't have autoimmune thyroid disease destroying the thyroid gland. As Dr. Wickland's work shows.
Yeah, shows that, because for myself, being a naturopath in Australia, we can't order blood tests, or we could order them, but the patient then pays for them, whereas if a doctor orders blood tests, they go through our Medicare system where the government covers that. So it's very difficult to gain the cooperation of physicians in testing things like thyroid antibodies, especially if the TSH, T3 and T4 have come back as normal. But in many, many cases, I don't think I've had one actually that didn't come up with high antibodies when I really pushed for the test because I suspected that there was something going on in the autoimmune area. So if the immune system is attacking the thyroid gland or thyroid hormone, do people with high antibody counts still benefit from the T3, T4 approach or just the T3 approach?
Well, the majority of them are simply hypothyroid, and they do benefit from a T4, T3 combination. I should say parenthetically, however, and some of my colleagues over here would disagree with me, but I would debate them on it. Any patients who can get well on a T4, T3 product can get well on T3 alone. The only reason we'd recommend T4, T3 for hypothyroid patients is for political purposes. Well, just for example, last year, my dear friend, a major physician who's a researcher on my research team, Richard Garrison, died from a pulmonary embolism at a very young age, 52. And he had hundreds of patients under his care on T3. Those patients will disperse now to other physicians who will, out of intimidation by the endocrinology specialty, either try to get them to go on T4 alone and may put them on T4, T3 products. But most of them are frightened of T3 alone, misled into thinking that a patient will drop dead from a heart attack if she swallows 2 or 3 tablets of T3. And
which is what I've had patients tell me, that their doctors say that, no, I can't give you T3 because, you'll have a heart attack. Where did that come from?
Well, I think it got filtered down from some endocrinologists did study, I think where this sort of nonsense began, is they did studies of elderly sedentary patients and found that the ones who had suppressed TSH levels had a higher incidence of atrial fibrillation, whether the heart's electrical activity is really going wild and circular. And it was a very quick, since T3 is highly